Hi, my name is Amanda Ragosa, and here's a critical review of my Level 1 fieldwork. The setting I was placed in was an outpatient nonprofit dementia care center. The setting had a welcoming atmosphere and had an open lobby up front and locked doors with alarms in the back. There was no OT on staff, but there were other staff members such as a PTA, a few caregivers, and a board of directors. This facility is open from 9 a.m. to 3 p.m. Mondays through Fridays and provides services to around 20 participants each day. Their mission is to provide services to individuals with Alzheimer's disease and other related dementia, provide support to their caregivers, and educate and inform the general community about issues related to dementia care. While the facility was rather small, they provided lunch to participants each day, regular music groups before lunch and at 2 p.m., and access to a small library and outdoor seating area. I'll begin this evaluation with a review of the literature and defining relevant terms. The medical model is a framework that sees the client and their diagnosis as the problem and as their identity. It is also known as a medical illness, disease, or diagnostic model. With the medical model, there are three common responses: conflict, which is openly dissenting the medical model; compromise, which is strategically stepping into the medical model; and colluding, which is inadvertently slipping into the medical model. Another type of framework is the psychosocial model. This is a framework that focuses on relational, interpersonal, and social contexts of distress. It sees individuals in the context of their own environment and involves more empathy and compassion. It looks at individuals in the context of the environment and how that has an impact on their physical and mental wellness and their ability to function. Some client and team related strategies that are used for working helpfully involve focusing on clients, foregrounding clients' context and understandings, holding tension between expert and not knowing approaches, using ordinary language, and recognizing one's power and ability to influence. Occupation-based is intervention chosen by the OT using engagement and occupation as a therapeutic agent of change. Occupational injustice often occurs due to social and institutional policies and governance that exerts power to restrict participation of individuals or communities in everyday occupations. Occupations as ends is when occupation is the goal to be learned. It directs our concern towards clients' occupational health, and it should not be limited to the goal or outcome of occupation-centered treatment, but can be the overarching goal of OT interventions. Occupation as means is when occupation is acting as the therapeutic change agent to remediate impaired abilities or capabilities. And component-driven practice is a shift away from occupation, and it bears the assumption that changing underlying components will create change in occupational performance. The client I'll be focusing on is named Isabella. Isabella was a Hispanic woman in her early 90s. Her dominant language was Spanish. She was diagnosed with end-stage dementia and had been receiving outpatient dementia services for 7 years before she passed away in March 2022. Isabella had 3 children. One of them passed away recently due to COVID. She was in hospice while attending outpatient services before she passed away, and she had a good relationship with her 2 remaining children who continued to provide her with support. Isabella enjoyed music in Spanish and dancing. However, due to her diagnosis and occupational injustice, she often experienced limited opportunities to engage in meaningful occupation. Some of her roles included mother and friend, and some of her strengths as listed by her family members were persistent, determined, and family-oriented. Isabella and her family's main goal was to overall enhance Isabella's quality of life. One day when I was at my fieldwork site, I got to meet Isabella's hospice nurse. When interacting with the hospice nurse, she explained how she believed that Isabella's progressive diagnosis of end-stage dementia would prohibit her from engaging in meaningful occupations, and that she no longer needed to attend outpatient dementia services. However, this did not align with Isabella's and her family's goals to continue attending outpatient services to enhance quality of life for Isabella. Rather than openly conflicting the hospice nurse's perspective and advocating for the client and the family's goal and incorporating meaningful occupations that involve the client's strengths, I inadvertently slipped into the medical model. I did this by engaging Isabella in a sensory activity following the interaction with the hospice nurse that was not occupation-based. It was simply an activity that aligned more with a medical model perspective, as it did not involve occupation and was more focused on something that required limited engagement from the client. The activity itself was a sensory activity involving putting lotion on the client's hands, and so occupation-based and occupation as means approaches were not achieved. After initiating this activity with Isabella, I was able to meet her family, and this is where I discovered that Isabella enjoys music in Spanish and dancing. They showed videos of her in the past singing to Spanish music and showed photos of her from her past as well. Incorporating music within this sensory experience would have been much more occupation-based and meaningful for Isabella overall. Some barriers to being occupation-based included limited staff to engage with the client one-on-one, and initiation of group interventions that were not suitable to the client's needs, and working with clients like Isabella who were unable to verbally communicate interest due to progressive end-stage dementia diagnosis. Adherence to a medicalized discourse may help to maintain the blame culture by promulgating the narrative of the expert helper who can avoid adverse outcomes by conscientious application of procedure. In order to initiate change, we need to have an open discussion about issues both at a policy level and within individual teams, as this can provide us with further information about how we can best support our clients. As future OTs, we need to recognize our power and ability to influence good within the system. We need to initiate collaboration with clients and their family members to provide more occupation-based interventions, and we need to utilize client strengths within our interventions as well. Thank you for listening.